Hello, my name is Kristen Waite-Labatt, and I'm going to be talking to you today about substance use disorder in healthcare professionals. And I'm going to be sharing my personal story also. I graduated from Winona State University in Winona, Minnesota in 1991, which means I've been a nurse for 29 years now, which is crazy to me. And after graduation, I went to work at Waukesha Memorial Hospital in Waukesha, Wisconsin. And that is about 15 or so miles west of Milwaukee. I went to work on the pediatric unit there and really fell in love with pediatrics. I worked there for about 5 years. The only thing I didn't like about it is that the Children's Hospital transport team would come and take our very sick patients over to Children's Hospital for care. I just didn't like that because I wanted to take care of them. So after about 5 years, I went to Children's Hospital, applied for a job in the critical care float pool, and got that position. Really loved it. I worked in the emergency room, the recovery room, the intermediate ICU, the pediatric ICU, and the neonatal ICU. I did that for about 3 years and then decided to move into the emergency room. That was my favorite of all those areas, and trauma was my most favorite out of the ER. So I worked there for about 3 years, did night shifts, 12-hour night shifts, 3 days a week. I really liked it. After about 2 years or 3 years, somewhere between there, I heard that a opening came up in the transport team, and they didn't come up very often. So I applied for it and I got it. And I was so thrilled. I really worked the previous 10 years to get enough experience to apply for that position, because when they would come and take my patients at Waukesha Memorial, I was always bummed about that because I wanted to take care of them. So finally I made the job on the transport team. And I got to do that job for 2 years and 7 months, after which I was fired, lost my nursing license, and ended up spending about 4 months in jail for stealing drugs from that hospital. So I have a very personal stake in this issue of substance use disorder in healthcare professionals, and I hope to raise some awareness and decrease stigma so that people are more able to help others and know what to look for signs in their coworkers or maybe even in themselves. The learning objectives for today's presentation: participants will gain an understanding of the opioid epidemic in this country and substance use disorder in healthcare workers, identify why substance use disorder happens, develop the ability to recognize a coworker with substance use disorder, and then discover how to direct a coworker with substance use disorder to helpful resources. Let's review some current events. In January of this year, in the Desert News from Salt Lake City, Utah, the headline read, "Ex-nurse sentenced to prison for stealing drugs, infecting patients," and that was with hepatitis C. In January also of 2020, Care 11 in Minnesota, nurse convicted of stealing meds had history of complaints. And then in May of this year, in the Pittsburgh Post-Gazette, UPMC nurse arrested for allegedly stealing patients' drugs. And in August of this year, in the Mountaineer from North Carolina, nurse charged with stealing drugs after alleged overdose. So you can see that it is a current problem. It isn't something that just happened 15 years ago to me. It's happening all over the country, really all over the world, every day in hospitals and clinics. It needs attention. We need to talk about it so that we can learn to recognize it and what to do when we do. Where do we go? What do we do? So we're going to talk about that today. Let's talk about the opioid epidemic that's facing this country. I imagine you've heard of it. One way that we measure that is by looking at the drug overdose deaths. So if you look at the graph on the slide, the national drug overdose death rate for all drugs, not just opioids, but all drugs, has really steadily increased over the years. In 2017, it peaked at just over 70,000. And then in 2018, it actually went down a little bit, which was really encouraging because, as you can see, that was the first time that it had decreased in a year. And in 2019, it was back up a little bit, not up to the level in 2017, but still close to 70,000. However, in 2020, they're predicting an increase of 18 to 30% due to the COVID pandemic that we're all experiencing. So it remains to be seen what 2020 shows. And just to give you an idea of how many people that is, that I looked up the population of College Park, where I'm not sure if you're all there, but probably the majority of you. The population in 2018 of College Park was just over 32,000. So if you can imagine, like, doubling the population of College Park, and that's how many people died in, a year's time in 2018. And so it just kind of shows you how, I mean, if a whole city was wiped out by a disease or something along those lines, people would really pay attention. However, not enough attention, in my opinion, has been paid to the overdose epidemic, even though those deaths are really quite high. This slide shows you the difference between the different drugs and the overdose deaths throughout the years. I want to draw your attention in particular to the yellow or gold line, where you can see in 1999, barely any deaths from that. In 2015, really started to go up, and in 2018 was leading by a large margin. That line represents synthetic opioids like fentanyl, and I'm going to talk more about fentanyl in a little bit, but just take note of how much that drug overdose death rate has climbed over the years. And if we break it down even more, look at just opioid overdose deaths, and please remember that includes opiates and opioids. Same kind of a curve where steadily increased through 2017, and then in 2018 we had a little bit of a decrease. And 2019, I didn't get that data yet, that wasn't available, but I imagine it will follow suit and be back up a little bit, and again this year probably even higher. When we look at fentanyl national drug overdose deaths, you can see how in the early 2000s, not much on the radar, but starting in 2014 and particularly in 2015, the overdose deaths from fentanyl increased significantly. In 2017, there were 29,400. Of that, 70,000 total drug overdose deaths. So that's 42% of all drug overdose deaths were attributable to fentanyl. And then in 2018, where we saw the other drug overdose deaths decrease a little bit, fentanyl did not. Fentanyl again increased, and in 2019 again increased. And I imagine in 2020 it will be increased again. So fentanyl is a fully synthetic opioid analgesic. So it's nothing natural about it. It's completely manufactured or made in a lab. It is 50 to 100 times stronger than morphine and is extremely addictive. All you need is a little bit. It's measured in micrograms rather than milligrams. So I'm going to share some of my substance use history with you now. I did not really start using any substances until college. I went to college when I was 17, turned 18 that October, and felt completely free. I went all the way to Minnesota, far away. It's only about 200 miles, but I felt far away, and I felt very free. I also had some social anxiety and had no real idea of how to be on my own. And I remember we celebrated my 18th birthday by drinking, as I imagine most people do. And I just remember feeling like I really loved that feeling that alcohol gave me. It made me kind of comfortable in my own skin. The anxiety that I felt around other people was gone. I thought I was funny. I could talk to people, I could laugh, and just enjoy myself. So I did enjoy myself with alcohol a lot during college. So much so that I didn't make very good decisions when I was drinking, so I ended up pregnant, and I had my first daughter when I was in college. And I took 6 years to get my 4-year degree. And really the only reason I graduated was because I did have my daughter and cleaned up my act for a while. After graduation, came back home to Waukesha and felt really pretty good. I was, a responsible adult now. I had a job in Waukesha Memorial Hospital in the pediatric unit, and really felt good. Didn't drink a whole lot. On occasion, when I did drink, it was mostly by myself after my daughter had gone to bed, isolation, and I would drink to pass out until I passed out. But So binge drinking and, maybe once a month. Then I started dating my first husband who liked to drink. So I started drinking again. We went out often and I drank a lot again. We ended up getting married, and it was not a very happy marriage. He drank a lot and wasn't always very nice when he drank. And then in 1997, I had a minor surgical procedure, and I was prescribed Percocet. And I found that I really liked Percocet, even more so than alcohol. What I liked about it is that I could take it and people wouldn't necessarily know. So I didn't smell like alcohol, I didn't slur my words, I didn't act goofy, but I had that same buzzed feeling or that same relief of anxiety feeling. And so I took those Percocet, until they were gone, and called for a refill, even though the surgical pain, I didn't need it for that. But the doctor gave me a refill, and I remember taking those till they were gone. Also, always finding reason to take them. Like I would make an excuse that, oh, I think I'm getting a headache, I better take a Percocet. Or, oh, my back is achy today, I'm going to take a Percocet. Whether or not that was true. And so I took those till they were gone. And over the next handful of years, or few years, I didn't measure my dates that all these kind of things transitioned like I do my recovery or sobriety dates. But over the next few years, I obtained opioids periodically. My husband was a carpenter, and he injured himself, on occasion, as they do, nature of the job. He would go to the emergency room, and he always came home with some kind of opioid, Percocet, Vicodin, whatever it was. And I would always sneak some of his. Sometimes he'd give them to me willingly. Sometimes I would sneak them. And I remember one time calling in a refill for him, even though he didn't request it, he didn't need it. In fact, he didn't even know I did. But I called in the refill for him and took them myself. Then on occasion, I'd go to my doctor and complain of back pain. I always had back pain, but it was probably not to the level that I needed opioids. But I would ask for them, and she would always give them to me. And so it kind of went like that, but very few and far between. So I really liked them, but I wasn't at the point where I was obsessing over them or getting them very often. So then I remember sometime around the year 2000, I was working in the emergency room and realized like I had a patient that needed some kind of a procedure, maybe a bone setting or something. I can't remember for sure. And I had some morphine left over. At least I think it was morphine, but some kind of opioid left over. And I put it in my pocket. It just kind of occurred to me, that we throw away a lot of really good drugs. And I put it in my pocket, really not without thinking about it a whole heck of a lot. And I took it home and I took it. I injected it at home and really liked that feeling. Certainly much stronger and immediate, of course, than the oral form. And so I really liked that. Felt bad about doing it, but I had really convinced myself that it was just garbage and I wasn't doing anything terribly wrong. So over the next couple of years, I took med like that whenever I could, when it was waste. Like I didn't, at that point, steal it, at least in my own mind. I was just taking what was left over. And in 2001, then, I got the transport position. And certainly remember at first being so happy and excited in that role that I remember thinking to myself, I'm never going to do that again. That's over. I'm done with that. And within, I don't know how long, but I certainly, when I had leftover or waste medication, I would take it home with me. And then in the year 2003-ish, hard to put, again, a date on that. I didn't write it down. But around 2003, one of my transports had fentanyl. We would use fentanyl for intubated patients or, severe trauma patients. And I had leftover fentanyl, and it had been a very small patient. And the fentanyl we had ampules of 500 micrograms, and that was all it came in. We didn't have anything smaller. So typically there's like 1 microgram per kilogram for the patient. So I had a ton of fentanyl left over. And I was like, oh, this is great. This will last me a long time. So I took that home. I remember when I took that, I had an instant craving for more. It was very different. First of all, the buzz or the high was better, if that's the right word, but certainly stronger than any other med I'd ever taken. And I instantly wanted more of it. It was such an odd feeling, but I was almost excited about it. Like, oh my gosh, this is awesome. This is the greatest. So I ended up taking all of that fentanyl over the next couple of days. I had off, my kids were now with my, so at the same time too, my husband left and filed for divorce. So not only did I have this new job, and certainly a very stressful job. I loved it, but it was stressful. But my husband left, and so I was by myself that particular couple of, I think it was a weekend, but I was by myself and took all of that fentanyl over the next couple of days. Took enough of it that I would throw up. It made me sick, but it was, the pull for it was so strong that I took took a lot of it rapidly, I guess. So from that point on, I needed that fentanyl. It didn't have to be fentanyl, it could be whatever drug. If I didn't have any waste drug in a shift, I would steal fentanyl. In our transport packs, there wasn't any electronic, we have your Pyxis machine now, there are other variations, but electronic machines that you have to put your fingerprint in and all this kind of stuff. In our transport packs, we just had them in little cases. So I would steal the fentanyl and do all kinds of sneaky things to try and hide it or cover it up, which worked at first. But then after a period of time, the pharmacy obviously realized something was going on. And I went on a vacation to Mexico for a week with my two girls, because I had another daughter while I was married. And we had a wonderful time. I came back, I was rejuvenated, and I was like, I'm never taking any drugs again. I'm absolutely done with it. I'm never doing that again. And that first shift back from Mexico, I took the fentanyl. I walked in the door and immediately this craving overwhelmed me, and I took some. And at this point I was using at work as well. And I just remember thinking, why am I doing this? Like I had no control over it at that point, because I'm telling you, I was fully committed to never using again until I walked in and I knew that fentanyl was there and I couldn't resist it. And so I took some during that shift, and then, took the whatever remainder I had home. And my next shift at work then, when I came in, and I worked night shift, so, I came in, I think it was a Sunday night, and my manager was there, which was very odd, of course, because managers aren't there Sunday night shift. And she asked me to come with her and into a conference room. And I walked into the conference room, and there was a sheriff's deputy there and a detective, our head of pharmacy, head of security, all these people. HR was there. And I knew immediately, of course, that what was going on, and they confronted me, and I denied everything. They did send me home. They suspended me and sent me home. But later I was charged with 26 felonies for each vial of fentanyl they could prove I stole. 2 felonies for each vial. So there was 13 vials they could prove, although I had taken many more than that. And certainly all the waste medication too that they didn't know about. So I was subsequently arrested. I ended up at this point just getting one misdemeanor. So this happened in July of 2004. And by October, the court stuff was done. Like I had ended up with 1 misdemeanor and probation. So that was done, and that was a big relief. In that time, of course, the hospital had to report me to the nursing board, which they did. I also reported myself to the nursing board, which is an important thing to do. And I actually had to mail in my nursing license. At that time we had, wallet cards, and I had it laminated in my wallet, and I had to mail that back, which was a very difficult thing to do. And then in October, I, of course, was looking for a job. I'm a single mother now with 2 children. And of course, nobody wanted to hire me because, number one, I didn't have a nursing license. So I was applying everywhere, McDonald's, Walmart, grocery stores, that kind of thing, because I was pretty desperate for money at that point, and nobody would hire me. So in October, I applied at a doctor's office as a medical secretary. And during the interview, I just kind of laid it all out there, told him everything that had happened. And I'm like, I just need someone to give me a chance. And so he did. And very nice doctor. And to thank him for that, I started calling in prescriptions for myself under his name. That started when he asked me to call in a prescription for Vicodin for a patient. I called it in. It was very easy. And I was like, I just, again, hit with that overwhelming urge for opioids. So I called myself in a prescription. And I did that for a few months. So from October to January, I called in 9 prescriptions. At first, it was just like I did one, and I'll tell you, it was always going to be the last time. Every time I called them in, it was always the last time. So I called in that one in October, and then I probably didn't call in the end for a few weeks, although I took all the pills, within a few days of getting them. But as time wore on, in December and in January, it got closer and closer together, my calling the prescriptions in for myself. So eventually the pharmacy, when it was like 3 days later, I think at one point, the pharmacy called back to check with the doctor to make sure that the prescription was okay. And he, of course, said, no, I haven't given her any prescriptions. And they're like, oh, well, we have 9 prescriptions here from you. And so when I left, I didn't know that, of course, that they had spoken. And when I left, I went to the pharmacy to pick up the medication, and I was arrested again. This time I was charged with 9 felonies, and one of them stuck. So I'm a felon today. And I ended up spending 4 months in jail. And as hard as that was, because it was absolutely horrible, the worst experience of my life. I didn't get to see my daughters. It was just awful. It was what I needed, because I've been sober since that time. I'll share more about the story in a little bit, but that's really my substance use story. If we look at some current national statistics surrounding opioid use or misuse, about 25% of patients prescribed opioids for chronic pain misuse them. And there are a lot of chronic pain patients in this country. Not sure how many. Tried to find that statistic and I couldn't find it, but about 25% of them misuse. And an estimated 5% of that 25%, transition to heroin. Heroin is very similar to fentanyl, so that addictive nature is very similar, very addictive heroin is. And then about 80% of people who use heroin first misused prescription opioids, which I think is a very telling statistic. In the 80s, late 80s, early 90s, we started seeing pain as the 5th vital sign. We were to assess pain and treat it. So if a patient had pain, we had to get rid of it. So the opioid prescription rate greatly increased throughout the 90s and 2000s. We realized there was a problem. When I say we, it wasn't me because that was a long time ago, but realized there was a problem with the prescribing rate. So in 2013, 2014, the rate of prescribing has been going down, and it really is significantly down from what it was. The problem is we still have a bunch of people with substance use disorders, with overdoses, even though the prescribing rate is down. And that's because we've created all of these folks with substance use disorders, and the treatment of them and the care of them has not caught up with the prescribing rate going down. The other problem is that those chronic pain patients who really rely on opioids for pain control are having a difficult time getting pain control and getting their pain taken care of the way they really need it to be. So a couple of issues certainly related or surrounding opioid misuse, and they need to be worked on. And I know there are lots of folks that are working on that, or working on those issues. But it really is a big issue in many different respects. So let's look at drug diversion and healthcare workers. Drug diversion is the transfer of a controlled substance from a lawful or legal source to an unlawful or illegal source or channel for distribution. So every time that I took even the waste medication at the hospital I was working at. When I snuck my husband's opioids, when I went to the doctor and made up symptoms so that I could get opioids, and certainly when I was stealing the drugs, it was diversion. That's what we call diversion, diverting it from its intended purpose. And so if you look at the chart in front of you, doctors were 30% of the known diverters in 2018, and nurses were 30%, doctors 37%. Some years, in fact, most years, nurses are more than doctors. For whatever reason, in 2018, doctors were a little bit higher. And then the other healthcare-related diversion folks are there as well. But nurses and doctors certainly top that list. Some statistics around healthcare workers and substance use disorder. So the American Nurses Association says about 10 to 15% of healthcare workers, nurses in particular, have some form of substance use disorder. And that prescription drug abuse is about 5 times higher among healthcare workers. So that's not saying illegal drugs, but the prescription drugs is certainly higher in those who have access to them. 94% of diversion accidents involve opioids, which just speaks to their addictive nature. And it's an estimated 37,000 cases of drug diversion occur every year. I guarantee you it's much higher than that. You know, when they do a survey or when they look at statistics, people aren't raising their hand like, oh yeah, count me for 5 this year, or, I know that I diverted many, many times before they caught me, and of which they had no idea, because I was taking waste away, or just taking what we were going to throw away. So they didn't know. So I guarantee you 37,000 is way on the low end of what actually happens. And then about a third of all disciplinary actions taken against nurses by a nursing board are alcohol or drug related. So why does this happen? Why are nurses succumbing to this substance use disorder so readily? Lots of different reasons. Relief from stress. So if you haven't heard, nursing is a stressful job. A lot of other jobs are stressful too, though. So why nurses? I think part of that reason is that we have easy access to the medications. It's better than it was in 2004 when I was diverting. We have Pyxis machines that need fingerprints, and we have cameras and all the security, which is great, but it's still very easy to divert medications if you are so inclined. Main way that it happens is when the medications are taken out of the Pyxis and then given to a patient, or rather not given to a patient. So a nurse or doc, whoever, provider, would give half to the patient maybe and take half for themselves. Some are sharing the needle as well, putting the needle in the port and then putting the needle in their arm or leg or foot or wherever it is they're injecting, and then taking a little and then giving a little bit more to the patient. And we're seeing, certainly if you Google it, you'll find many stories of transmission of disease, hepatitis C, HIV, very devastating to families, and nurses and other folks who are diverting are getting long prison sentences for such things. So relief from stress, self-medication for things like anxiety and depression. I know I had a lot of anxiety and depression, certainly a lot of anxiety, some depression for most of my adult life. Sometimes I treated it. I didn't treat it, but sometimes I went to a therapist and got medication, and I'd feel better and I would do better for a while. But then I was doing great. So I took, without consulting my doctor, I would go off the medication and then start to do it poorly again. And then my drug and alcohol use would increase. I never correlated that in my head, even though I'm a nurse. It didn't occur to me that if I just kept treating the depression and anxiety, that may help my drug use, or help maybe, but decrease it a little bit. I don't know. I did go to a therapist in the springtime of 2004. So remember, I got caught in 2004 in July. In spring of that year, I had gone to a therapist because I really wanted to quit. I felt so bad about what I was doing. I knew it was wrong and I felt terrible about it. And, I came clean with her and told her everything. And And she said, well, we have to get you inpatient, and you have, you need to do this and you need to do that. And I was like, whoa, whoa, whoa. So I can't do that. I have a job I have to go to. I have 2 daughters I have to support. I can't do that. And so we kind of worked out a compromise that I would come to her twice a week. And if I couldn't stop using, then I would have to go inpatient. And so the fear of going inpatient was very strong. And so I continued using, but I didn't tell her. In my mind, I was thinking, if I just keep going to therapy, I will figure out what's wrong with me and I won't need to use anymore. In reality, I needed to stop using so that I could work on the things that led me to that to begin with. But when I was, taking drugs and alcohol, I wasn't in my right mind to deal with those things. So, and then certainly can follow surgery, injury, or an emotional loss. So my, opioid use started after my surgical procedure in '97. And every time it escalated, so when I transitioned to IV stuff, when I transitioned to fentanyl, things were happening in my life that were very stressful. I remember we were having a very difficult time in my marriage when I first took the whatever drug it was, that first time when I took that IV waste in 2000-ish. And I know that when I transitioned to fentanyl, my divorce was final and I was feeling like just such a failure and so depressed and just miserable and scared too, because I didn't know what was going to happen, how I was going to be able to support my 2 girls and be okay. So certainly in those times, my use increased. And we have easy access, as I've already talked about. And then denial and enabling. My denial was so strong. Like when I was taking waste, I absolutely denied that there was much wrong with that. Obviously, I knew taking drugs was wrong, but I justified it in my head and believed myself, which is very odd. It's an odd feeling. And when I look back on it, it's very odd. I also denied that anyone would notice. So once I started stealing it from the stock and making changes to the log, and I remember one time crushing the ampule and squirting saline and putting it back in the kit, thinking that they would just think the ampule broke. Stuff like that. And I was like, nobody even looks at this anyway. It's no big deal. And enabling, my peers, there were certainly signs that I displayed that, had they known what to look for, may have clued them in. I'm not at all blaming them, not even a little bit, but there certainly were signs that if they knew, maybe they would have been able to help. And then genetics, there certainly is some thought that genetics plays a part in substance use disorder. And certainly on my dad's side of the family, there is a reasonable amount of, nothing about addiction is reasonable. There's a fair amount of addiction on his side of the family. So perhaps genetics plays a part. And then how do we do it? I've told you a little bit about how I did. But so administering a partial or no dose to a patient, I remember giving, like when I had a trauma patient, I would give them some and then I would put the rest in my pocket for later. And knowing that if they needed more, they would get it. Like they could just have as much as they wanted. So it wasn't a big deal that I was taking it, which of course isn't true, because then if I didn't give them all of the medication that they required at one time, then they were suffering for longer than they needed to. But my thinking was, well, they can have as much as they want. It's no big deal. It's just ridiculous. But ask a colleague to co-sign a narcotics record. Of course, we have to have a witness when we waste narcotics, right? Or controlled substances. Narcotics is an old word. And so I took full advantage of that. And it happens every day, all over the place. I wouldn't show them what I wasted, or I would have saline in a syringe that I did show them, but I would just say, hey, can you go sign my morphine waste? Oh, sure. Can you go sign my fentanyl waste? Oh, sure. And they would sign off on it. Nobody ever asked me to see it. Nobody ever questioned it. And I guarantee you, I did that many, many, many times, and as do others. Obtain PRN or as needed medications for patients who have not requested them. Oh, you don't need your Vicodin for your surgical pain? Oh, okay. Then I'll take it. Steal medications, as I've talked about, and alter drug records. So I did that. When we did the controlled substance count, and then later I'd go back and change the 6 to a 5. I did it one time in blue pen when the original was in black pen. They showed me this when they confronted me, and I had a vague memory of doing it, and I'm like, I look at that and I think, what was I thinking? Like, if all you have to do is look at that, it's very obvious that that was changed. So that denial in my brain was very strong. As providers, they work for to write a prescription. Hey, you know, I have this really bad tooth pain. I can't get into the dentist till Monday. Can you just write me, you know, a script for 5 Vicodin? Sometimes providers would do that. I didn't ask them. I didn't need that, but I didn't do that. But many people do. And I don't think it's as common anymore because you have to, most anyway, are electronic prescriptions. So I don't think that's as common. But if you end up ever doing prescribing, please just be cautious of that and don't prescribe for family, friends, that kind of folks, not the opioids. Steal scripts, forge prescriptions. So again, I don't think there are a lot of people that use paper prescriptions anymore. If you're in a facility or a place that does, encourage them to get rid of that and use electronic. It's just more difficult to alter that way. And then calling prescriptions to a pharmacy. I told you the second time I got in trouble, that is what I did. That's reasonably easy to do as well. And then provider shop, or go from provider to provider, getting scripts from different providers for different things or even the same thing. That's somewhat prevented now by the PDMP, which I'll talk about in just a little bit, but certainly still common that folks will try and do that. And so coworkers have a vital role in recognizing substance use disorder. When you work with someone, you get to know them and you'll be able to see those sometimes quite subtle signs. Some of those signs are increasing work absences. So those with alcohol use disorder perhaps will be too drunk to come to work or too sick to come to work. Those who have opioid use disorder come to work sometimes more than they'll show up even on a day off because that's where we get our drugs. So we want to be at work so we can get them. So increasing or decreasing work absences. Extended breaks or bathroom visits. So at the end, I was a smoker at the time too. So I would just say I'm going out for a smoke break. But at the end, it was like every half hour because I was going to the bathroom and using. But I would lie and say I'm going out for a smoke break. So extended breaks or increasing breaks, bathroom visits. Shakiness. So I'm a little shaky anyway. I have some benign essential tremors. But they were so bad by the end of my using. I remember one time being on a transport and I was shaking so bad and I had to put a needle into an IV port, which we don't really use needles for that anymore, but anyway. And I had to actually steady my hands on the bed because I was shaking so much I couldn't get the needle into the port. The respiratory therapist that was with me saw that and he looked at me, but didn't say anything. And that was it is a change in the person. So where I went from being, you can hardly notice my shakes, to shaking so bad I can't get a needle in a port, that's a big change and maybe want to question that if you see it. Wearing long sleeves when inappropriate to hide needle marks. A personality change, so irritability or agitation or snippiness, or someone who is very friendly and outgoing is all of a sudden withdrawn and irritable. Those changes are what you really want to look for. Changes in appearance, so where someone who's well-groomed all of a sudden is coming to work disheveled or unkempt or maybe greasy hair, that kind of thing. Just a change. Falling asleep during downtime, so that opioid nod where they just can't keep their eyes open. That doesn't mean that everyone who falls asleep in a boring staff meeting is a drug addict. However, if it's a change, you might want to consider it. And then volunteers to administer narcotics to patients or controlled substances. You've been working so hard, you look really tired. I'll go get that morphine for you and give it to your patient. And then probably coincidentally would ask, can you co-sign the waste record? So just things to take note of. It's not, being helpful is great, and I'm not suggesting everyone who asks, to give meds for you to be helpful to you is an addict, but just something to take into consideration. Maybe you would couple that with some other signs that you saw. And suspicious drug log entries or changes, like I've talked about already. Drug discrepancies, certainly if drugs are missing, could be a clue. Altered verbal or phone med orders. So again, for prescribers, if you call in an order for a controlled substance, and when you go to co-sign that order, please pay close attention to what the order is. Sometimes folks it's busy, right? It's a busy job. We'll just co-sign without really looking closely at it. But be careful, and particularly for opioid orders, look at it very closely and make sure that it wasn't increased, because that's one way also people cover that up, because maybe you order 2 milligrams of morphine, they put in 10 and they take 8 and give the patient 2. Patient reporting ineffective pain management. Certainly if you're taking a patient's medication, they're not going to have good pain control, or it's possible. Heavy wastage of drugs. So I did that all the time. If I needed 1 milligram of morphine, I was pulling a 10 milligram syringe. Incomplete charting and practice errors. So I don't know that I ever made an error, not that I know of, but I certainly don't know that because I was impaired while I was working. And so I can't be sure that I never made an error. And that is very difficult for me to say out loud and to accept. But I think it's really important to say that, because that's what this is all about, is making sure that our patients are safe. And if I'm working and I'm impaired or I'm not up to my full potential, I am certainly not giving my patients the best of care. So that's something that bothers me greatly. But again, I help myself deal with that by speaking about it and at least trying to prevent it from happening, at least as much as I can. What else can you do? You can refer. So if you have a peer who looks to be in trouble, you can talk to them about the EAP, or the Employee Assistance Program. Most bigger facilities have that. You can also direct them to counseling or treatment programs. The hard part about that is insurance can be really overwhelming, particularly for someone who is in a desperate state. So offering to help them look that kind of stuff up through their insurance is very helpful. You can refer them to 12-step programs. So particularly for those who have lost their job, 12-step programs are free. And then there are other programs as well, like Smart Recovery and Celebrate Recovery. Those are also free and a little less spiritual, as 12-step programs tend to be. Encourage them to report themselves to the nursing board. That's really a big step in moving towards recovery. And they have to be reported anyway. So if the hospital reports them, if they've reported themselves already, it just, number one, looks better, I guess, to the board. Shows them that you're really serious about getting into recovery. But it's really an important step for the individual. It gives them first a sense of closure, like I've done this and I'm ready to get help. But it's also very brave. And if they can do that, then it kind of gives them a little bit of courage to keep going. And then, of course, you have to report them if necessary, but offer them support as well. So once I was fired and it was all scary and a big mess, all of my peers who were very angry and confused and upset, despite that, reached out to me. I had good relationships where I worked. I was a really good nurse. I got exemplary reviews. I never had any incidents or was never in any trouble. So people were very shocked when they found out it was me. And they wanted to know why. So they called me, but they offered their support, sent me cards, sent me gift cards, because of course I lost my job. So they would send me, they were just so wonderful. So despite the fact that they were upset, they also wanted to help. And I found that very, very encouraging. I didn't call them back. I didn't return their letters. I was just so ashamed and so overwhelmed. But it really did mean a lot to me that they were trying to reach, or that they, not just trying, but that they were reaching out. It meant a lot to me. And what if it's you? Get help. Please remember that you are not alone. There are thousands of other nurses struggling with addiction. Addiction is progressive. It doesn't get better over time. It gets worse. And there is help, but you have to ask for it. You have to reach out and grab it. And please do that, because if you can do that before your whole world falls apart, things are much better. For me, it was very difficult. So I'm going to talk a little bit about my journey to get my nursing license back also. And then there are resources that I'll review with you at the end of the presentation. There is a program for nurses in recovery that allows them to get help and continue to practice. In Wisconsin, it's called the Professional Assistance Procedure, or PAP. Why a nursing board would name a program PAP, I don't know, but I find that a little funny. In Maryland, there's a similar program called the Rehabilitation Program. So there are two forms. One is confidential and one is public record, but the programs are really virtually the same. And if you can report yourself before you get in trouble, before you do anything illegal, you can enter a confidential program. And the benefit of that is that your nursing license, when somebody looks it up, doesn't show any of the procedures that you went through, any of the details of your substance use disorder. If you have legal issue like I did, the nursing board has to show that they've done something to address that. So anything that I went through the nursing board and that program that I entered is all public record. So if you look at my nursing license, and I suggest you do, you can see everything that happened throughout, my program, that program, well, what led up to the program and then in the program. And so what does that program consist of? Well, it's a 5-year program. In Maryland, it said up to 5 years. So it may be that in Maryland you have some shorter. I'm not sure about that, but in Wisconsin, 5 years for everybody. But it allows nurses with substance use disorder to obtain treatment without losing your license. So again, the confidential, you have to kind of turn your license in, or they suspend your license temporarily until they can show that, or until you show that you are in treatment, that you're following what the recommendations are, and that you're getting your urine drug screens completed. The board will monitor you through treatment. It doesn't give you treatment. It doesn't provide treatment. It approves what treatment you are getting and then monitors you through it and ensures immediate action if something goes wrong. So if a drug screen is positive or you don't show up for a drug screen, anything looks funny, they have the right to pull your license right away. And doesn't exempt someone from discipline. So even if you're in that program and then if they discover that you did divert or that you got a DUI or whatever, then it would probably revert to the public form of the program, again, so that they can show that they addressed the issue. Some of the requirements of that program: random urine drug screens, 56 a year, which was 1 to 2 a week, and 12-step meetings. You're required to go to 1 to 2 meetings a week. You're required to get a treatment-based assessment, and then whatever they suggest, you need to do. So if they suggest inpatient treatment, you have to do that. If they suggest intensive outpatient, which is what they did for me, you have to do that. And then you have to submit quarterly reports, or 3 reports, one from the person in the program, one from the therapist, and one from the work supervisor. They have to be done quarterly, and then the board collects all of the quarterly data, the drug screens, and all those reports, and reviews everything. And if it looks good, you're good for another 3 months. So they review everybody in the program, and there's like close to 400 people in that program in Wisconsin. Every 3 months, they review everything to make sure those nurses are still safe to practice. And then you'll get another 3-month stay of suspension, and they'll review again the next 3 months. And then you have to pay for all of that. So the urine drug screens, when I did them, were $35 each, and I had lost my insurance, so I had to pay for my counseling. And 12-step meetings are free, but everything else was very expensive. So a lot of nurses drop out because of that, because they just simply can't afford it. Limitations on your license. So obviously, if you have a problem with, with opioids, they're going to restrict your access to opioids. So one of the things they do, you can't work with opioids. Someone else has to give your, not just opioids, but all the controlled substances. You have someone else has to give those for you. You can't work with any type of staffing agency because you have to be supervised by a licensed person at or above your level. 100% of the time. So you can never work in a home health care agency or anywhere else that you're not supervised. Oftentimes night shift is out because night shift doesn't have as much supervision. So they put those kind of limitations, and they can impose other limitations and do individualize. They can add things too, but those are the baseline or the bottom line of the limitations. Some resources or places you can go to for more information or if you need help. Your Board of Nursing, so Wisconsin's Board of Nursing, I have a link to that here. The American Nurses Association, they have a ton of information and resources. AA.org and NA.org, Alcoholics Anonymous and Narcotics Anonymous, 12-step programs. Treatment programs, so through insurance companies, inpatient treatment, intensive outpatient treatment, residential treatment, all those kind of things. Expensive though, so insurance is a must for those. Not a must, I guess, but if you can work through insurance, that's certainly helpful. Family members, so if you're concerned about somebody and you know their family, maybe talk to their family and say, hey, I'm worried about Sally Mae. What do you guys think? And then recovering addicts like me. My phone number is here. I'm more than happy to talk to anyone if you just want more information. If you're worried about somebody or if you have an issue yourself, please feel free to give me a call. You can also shoot me an email. So I'll share this PowerPoint, but my email, phone number, and all that will be there. I would love your feedback. I really want this presentation to be meaningful and to have the information in it that you need. So please follow this Google link. It's a long link, so hopefully you'll get the link electronically and you can just click on it. Really only takes about a minute, but I would really value your feedback. Ways I could improve would be very helpful. And I did write a book about my journey, so believe it or not, there's more to the story. If you're interested, you can get it on Amazon. It's $10. It's called An Unlikely Addict. I also write a blog on occasion. It's blog.unlikelyaddict.com. My contact information is here, email, phone number. Please reach out if you need help. Thank you for taking the time to listen today, for keeping an open mind, assuming you did. Hopefully you have some decrease in stigma around those of us with substance use disorder, because we're really everywhere in all communities and all hospitals, clinics. Hopefully you'll run into someone with a strong recovery and be able to help someone if they need it. I think that's all I have to say. I really appreciate your time. I do have references as well. If you want to look those up or are interested in more information, please don't hesitate to reach out to me. I hope you all stay well. And again, thank you for your attention.